Hello, class. This is part 2 of our review of the stages of the normal swallow. Now, as you probably recall from last time, the pharyngeal phase is where we left off. We'd already discussed the oral stage, including possible subdivisions into the oral preparatory stage. We discussed the transit or the movement of the bolus as it moved from being masticated and processed to the posterior aspect of the oral cavity. And we had begun to talk about how the pharyngeal phase is very different from the oral phase in that it is largely involuntary. So this is where we're going to begin today. One thing we didn't talk about is essentially what is called the swallowing reflex. Because this stage of the swallow is involuntary, it is often described by those talking about dysphagia and disorders of swallowing as being a swallowing reflex. It is controlled by a specific area of the brain, often called the swallowing center of the brain. Let's go ahead and take a look at a terrible drawing by someone, that would be me, that's meant to depict different structures that are important when you're thinking about the swallowing center. Now, as you probably recall from neuro, the behaviors that are called reflexive are mediated by brainstem centers. The neurological swallow center is no different. It is mediated by a site in the medulla, one of the structures of the brainstem. So if you're looking at this drawing, this would be the medulla. This location within the medulla then is what is considered the neurological swallow center. And innervation then proceeds along the length of eventually the esophagus, but certainly the pharynx, and there is some sensation and motor going towards the velum. This is important because the swallowing reflex can take place from stimulation to the velum, to the posterior aspect of the pharynx. Those are the most common. Certainly, the weight here of the bolus continues to trigger reflexive openings, for example, of the port into the esophagus. So we'll return to this picture in a moment. Let's go ahead and talk just a little bit more about this so-called swallowing center of the brain. So the bolus stimulates the receptors which project up to this portion of the medulla. It is called the nucleus tractus solitarius. It's a reticular formation in the medulla. It incorporates sensory receptors and essentially is the center that integrates and begins reflexive movement that characterize the pharyngeal phase of the swallow. So what are the events that take place in the pharyngeal phase? We know that it has to be a series of events that begin as the bolus passes the ramus of the mandible. And there are a number of events, and if you've started your MB-SIMP training, then you know that you could probably recognize some of these activities when you're looking at a video swallow piece of film. So, for example, you know that there is anterior and superior movement of the hyolaryngeal complex, that there is closure of true and false vocal folds. This you cannot see on a video swallow view, but it is something that you can evaluate at least in terms of the after effect of this action, when you're looking at another type of instrumentation, and that would be fees. What else happens in the pharyngeal phase? Well, there is progressive pharyngeal contraction, such that the upper part of the pharynx contracts, and sequentially then contraction or movement of the posterior and lateral pharyngeal walls takes place as the bolus moves inferiorly. At the end of the pharyngeal phase, the upper esophageal sphincter needs to open so the bolus can head into the esophagus. Again, something that you might know from MB-Simp is that there is in fact another name for the upper esophageal sphincter. That would be the PES, the pharyngoesophageal segment. So let's go on and take a look at another sort of interesting depiction of the structures involved in the pharyngeal phase. If you look superiorly then, you can see the area where the bolus was. The bolus in the pharyngeal phase passes through here, past the opening to the airway, and heads towards the PES, or the upper esophageal sphincter. There is then this large esophagus, and that's the passage area for the esophageal phase. Right now, in the pharyngeal phase, we're only concerned with passage of the bolus here through the pharynx and eventually into the PES, or the pharyngoesophageal segment. What are some important landmarks that you should know at this stage? Certainly the pocketed areas in the pharynx. Those would be the vallecula and the piriform sinuses. In a separate slideshow, I have for you unnarrated some pictures that let you know the location of these indentations or pockets in case you can't remember them from your anatomy or your voice class. But the vallecula are higher, and they're located sort of in the depression anterior to the epiglottis. The piriform sinuses are inferior and posterior to the vallecula, and they are formed in the lateral aspect of the laryngeal vestibule, essentially. The lateral channels, which form sort of the passage alongside and outside of the main laryngeal structures, certainly bypassing laterally the opening into the trachea, the airway. The area epiglottic folds, which are these large folds on either side of the larynx, coursing from the lateral aspect of the epiglottis towards the arytenoid cartilages. The false vocal folds, not really vocal folds innervated to open and close, as you may recall, in the same way as the true vocal folds. They're superior to the true vocal folds, and while they do not entirely close the area above the vocal folds, they do constrict and can form something of a barrier in that region. What are the structures that are involved in velopharyngeal closure, another activity that happens during the end of the oral stage, as we talked about before, but also activities that happen, an activity that happens in the pharyngeal phase? Well, velopharyngeal closure takes place with innervation from cranial nerve 10, while there is, at the same time, opening of the eustachian tube. And we know this to be the case because when you're in an airplane and you feel too much pressure in your ears, you know that by swallowing several times or opening the entrance to the eustachian tube, that you can relieve some of that pressure. So swallowing has an effect on pressure in the ear. So again, to reiterate, velopharyngeal closure is something that happens towards the end of the oral phase and at the beginning of the pharyngeal phase to keep the bolus then heading south and not superiorly towards the nasal cavities. There are more muscles that participate in velopharyngeal closure. These are muscles innervated by cranial nerve 9 and 10. The superior constrictor, for example, is one of the muscles actually that participates not only in velopharyngeal closure, but begins the process of constriction at the most superior aspect of the pharynx. So it moves the lateral pharyngeal walls medially, and also helps a little bit in moving the posterior pharyngeal wall anteriorly. Other muscles that are active during this activity of velopharyngeal closure include the palatopharyngeus and maybe the palatal glossus. So you might remember from speech science that the palatal glossus is one of the muscles that helps to form the fascial pillars. And there is some thought that perhaps it also helps to modify the shape of the velum as the process of velopharyngeal closure is taking place. Just as that was an oral transit portion of the oral stage of swallowing, so there is also the pharyngeal transit portion of the pharyngeal stage. So once the bolus has passed into the pharyngeal area, then it begins its transit inferiorly, and this is accomplished by movement of essentially the base of the tongue and the contraction or constriction of the inferior of the pharyngeal constrictors. The base of the tongue has to essentially move posteriorly and make contact with the posterior pharyngeal wall. There is then the sequential contraction from the superior, medial, and inferior pharyngeal constrictors. Now, at this point, we should probably examine the notion of peristalsis as a process in the pharynx. Peristalsis typically is used to refer to constriction that is rhythmic and repetitive. We find peristalsis, for example, in the intestines to help move bolus material continuously through the intestine until there is no more material to move. The pharynx is different. It doesn't have a continuous stream of food material in it. It has one bolus at a time, and because of that, there isn't continuous rhythmic contractions of the constrictors. Rather, simple top to bottom constriction of the pharynx takes place. So, although you will read in various places, including many sites on the internet, that there is peristalsis, it really is not peristalsis, but rather it is sequential contraction of the constrictors. The bolus then is moving downward through the pharynx, because of a combination of factors. Gravity certainly is helpful. It helps, especially if the mass of the bolus is relatively great. So that's one factor in bolus movement. In addition, as the base of the tongue retracts and the bolus is dumped, and then the base of the tongue retracts to make contact with the posterior pharyngeal wall, and this helps to cut off access to superior structures. But this action, along with the pharyngeal wall contraction, helps to establish changes in pressure, which also facilitate bolus movement. Now, we are not going to be finished in the pharyngeal stage until we also talk about actions in this stage that help to facilitate movement of the bolus, but also provide airway protection. When you talk airway protection, you have to talk about movement of the pharynx in terms of elevation. So we have just talked about movement of the constrictors, that they help to decrease the diameter in a sequential way, moving the bolus inferiorly. However, we also know that there are important muscles and also there are cranial nerves that cause elevation of the larynx. So all of those muscles that you were exposed to in voice, for example, that are laryngeal elevators, those muscles are important in the act of swallowing. Controlled largely by cranial nerves 9 and 10, muscles such as the stylopharyngeus help to pull upwards on the pharynx via an attachment to the styloid process of the temporal bone. So now we need to take a moment and think about what are all of the mechanisms that we have for airway protection. Certainly, hyoid and thus laryngeal elevation, much as we talked about in the case of the stylopharyngeus, that elevation helps to pull the larynx up and sort of away from the path where the bolus must proceed. We also have probably the best known airway protection mechanism, that would be the movement of the epiglottis. The epiglottis retroflexes or inverts and covers partially the opening to the airway. It is not an airtight closure. The epiglottis covering over the opening to the airway is a mechanical barrier, but it is not airtight and it cannot serve as the only airway protection available to keep material out of the airway. So we also know, we know that there are muscles that facilitate these two movements that we've talked about so far. That is, that the suprahyoidal muscles, so these would be muscles like the mylohyoid, for example, help to yank the hyoid forward and thus helps pull the larynx forward as well and facilitates the epiglottis tipping over into a more vertical position. What other airway protection mechanisms do we have? We have another also very well-known protection mechanism, and that would be the adduction of the true vocal folds. As you recall, swallowing is considered an apneic event, meaning that there is no breathing. And while we do take a breath usually before we begin the swallowing process. So we usually inhale at some point right before we begin the swallow. Most people exhale and then begin the swallowing process and then finish their exhalation. So it is a matter of taking in air as you finish the food preparation, a small amount of exhalation, followed by the actual moment of the swallow, followed by the rest of the exhalation. This is a worthwhile turn of events in that already the airflow has been reversed as the swallowing is beginning. So there is less of a tendency then to inhale food particles because airflow has already begun to proceed as if there were a regular exhalation. We know that the recurrent laryngeal nerves are responsible for innervating muscles that have to do with the adduction of the true vocal folds. Finally, we have activities that take place in the laryngeal vestibule. And by the laryngeal vestibule, I mean that area right above the true vocal folds. In fact, it is the area that has as its boundaries the epiglottis in the anterior aspect, the airy epiglottic folds in the lateral aspects, and the arytenoid cartilage in the posterior aspect. The laryngeal vestibule has as its most superior border the false vocal folds, or the FVC. The laryngeal vestibule, in addition to movement of the false vocal folds, also has the anterior movement, or the anterior tilting of the arytenoids. On MB-SIMP, this looks almost as if the arytenoids move so far forward, the apex helps to form a horizontal line. It is quite a bit of movement as far as the arytenoids are concerned, and it does help to follow tighter closure as the hyolaryngeal complex moves anteriorly. We know that even just the act of sort of closing the laryngeal vestibule a little bit more tightly, that this action can in fact help to expel material if some has accidentally started into the airway. We call that activity penetration. So if material has penetrated into the larynx, then the closure of the laryngeal vestibule, these kinds of movements here, will help to expel that material and send it back into the pharynx to head down towards the esophagus. With regard to hyolaryngeal elevation, what other muscles are responsible for this? Again, we know that these are muscles that would be suprahyoidal muscles, so the digastric, the mylohyoid, and the geniohyoid. Some of these we think about as also being sort of floor of the mouth muscles, but when there is contraction, if there is contraction, they can elevate and move anteriorly the hyoid, and the hyoid will drag the rest of the larynx with it. Innervation is cranial nerves 5, 7, and also 12. We know that as far as laryngeal protection is concerned, that any of the muscles that help the arytenoids, for example, move closer together. These would be the transverse, for example, arytenoids and the oblique arytenoids. Any of the muscles that are responsible for adducting the vocal folds, that would be the LCA, lateral cricoarytenoid, or the TA, the thyroarytenoid. Any of the muscular control over epiglottic inversion. So the movement, the contraction of the thyrohyoid helps pull forward and thus invert the epiglottis in the posterior aspect, sending it sort of horizontal also. The aryepiglottic muscle, we're not so sure what its function is, but it may help to participate in epiglottic inversion. Most of the innervation for laryngeal protection is completed by a cranial nerve 10. We come now to the opening of the PES-UES. The PES again stands for pharyngoesophageal sphincter, and the UES stands for upper esophageal sphincter. More and more people are beginning to call this the pharyngoesophageal sphincter and/or pharyngoesophageal segment, to indicate that it's not just one muscle that is responsible for the activity of opening the pathway into the esophagus. When we were calling it only the upper esophageal sphincter, we further sort of simplified matters and said that the cricopharyngeus muscle is the primary part of the UES, and you will hear people talking about the cricopharyngeal bar that they see on video swallow studies. We now know that it's really not just the cricopharyngeus that is the only player. There are other ends of structures, or the other portions of structures, which are also important to opening the PES. For example, the inferior pharyngeal constrictor is thought to help to stretch and open the PES. The proximal or close end of the esophagus is also thought to be a helpful structure that is part of the PES, the pharyngoesophageal segment. So the PES is thought to include the close end of the esophagus. By close, I mean that end that is the closest to the opening to the pharynx, the inferior constrictor muscle, and the cricopharyngeus muscle. All of those then contribute to activity that leads to opening of the pharyngoesophageal segment. This opening allows the bolus to enter into the esophagus, and it must happen before the bolus actually arrives. That opening is part of activities that contribute to a change in pressure in the pharynx, such that in addition to gravity, a sudden change in pressure encourages the bolus to drop further down through the pharynx and eventually into the esophagus. So, to sort of summarize, the UES, or the cricopharyngeus, if we want to say that, has to relax during the swallow, and this is crucial. If it does not relax, then the PES-UES cannot open. The fact is that in the early part of the swallow, the PES-UES is, relatively speaking, contracted. It needs to relax to allow the bolus to head into the esophagus, and it will then reinnervate or contract to prevent material from heading superiorly up and back into the pharynx. So we have relaxation of the UES, the elevation of the larynx, helping to pull the UES or PES open. And this is in part because the cricopharyngeus has some fibers that are attached to the larynx. And so when that larynx moves forward, the fibers of the cricopharyngeus get stretched a little bit. And when the cricopharyngeus further relaxes, then it increases the diameter of the opening. Once again, we see differential activity based on the nature of the bolus. If the bolus is a really large mouthful if we're talking about a solid, or sip if we're talking about a liquid, then the time that the UES-PES is open increases. If we have a small bolus, the opening of the PES is relatively short in duration. The pharynx contraction, or the pharyngeal contraction accomplished by the pharyngeal constrictors, also then helps to eventually contribute to activities that stretch or that pull or that in some way help to stretch the opening into the esophagus. I wanted to say a couple of words about things that can happen when the bolus is in the pharynx and in the case that material is not tolerated well, either because the pharynx is irritated or because material has entered into the laryngeal vestibule. There is coughing that happens if material has entered into the laryngeal vestibule, either because there was premature spillage or because activities that protect the vestibule did not occur. So if the epiglottis is slow in inverting, if there is poor anterior superior movement of the hyolaryngeal complex, then material could in fact enter into the laryngeal vestibule. And often, although not always, this triggers a reflexive cough. This reflexive cough is due to stimuli from the sensory portion of cranial nerve 10, and then motor activation accomplished also by cranial nerve 10. If you have a client who has damage to cranial nerve 10, either sensory or motor, then there will not be this reflexive cough that is so important when we are dealing with material that has penetrated into the laryngeal vestibule. There is another reflexive movement that takes place with stimuli to specific portions of the posterior aspect of the oral cavity, as well as the more superior portions of the pharynx, and that would be a gag reflex. Gag reflex we have probably seen most likely when we stimulated the posterior aspect of the tongue or the fascial pillars while doing an oral peripheral or oral motor exam. You probably already know that many individuals have very little gag reflex. And even in individuals who have a fairly robust gag reflex, that gag reflex varies depending on the nature of the stimulation. In any case, we know that a gag reflex, either an enormous activity of gag reflex or the absence of a gag reflex, is not predictive of anything about the success of the pharyngeal stage of swallowing. If someone does not have a gag reflex, it does not predict that they will have more severe dysphagia or that they constitute an unusual aspiration risk. This is not the case. Gag reflexes in this region are also have some involvement of cranial nerve 10, that would be for the motor aspect, and the sensory nerve, cranial nerve 9, provides the sensory information. We are now at the final stage of the normal swallow. We are at the esophageal stage. And recall that those events that we just discussed, for example, the opening of the PES, that was an activity of the pharyngeal stage of the swallow, and it has to happen before the bolus arrives at the PES because of the need for pressure changes that are accomplished that facilitate movement of the bolus. Once you are in the esophageal stage, the bolus enters the esophagus, and food is eventually carried towards the stomach. The processes that are responsible for this movement would be a combination of gravity and true peristalsis. So peristalsis can occur in the esophagus, as well as in lower gastrointestinal structures. Peristalsis then is rhythmic and sequential contraction of muscles around the esophagus that help move food towards the inferior aspect of the esophagus. In the esophageal stage, the lower esophageal sphincter must open, allow the bolus to pass, and then close after the bolus. We've already talked about the issue of peristalsis as applying or not applying to the pharynx. We also know from the voice class that you've taken that malfunction of the lower esophageal sphincter can lead to disorders such as reflux, where stomach contents are returned up through the esophagus and eventually find their way back into the pharyngeal aspect of the swallow. The esophagus joins the stomach as it passes through an opening in the diaphragm, which is called the diaphragmatic or the esophageal hiatus or opening. So the esophagus passes through the diaphragm and then via the lower esophageal sphincter into the stomach. Here again is a depiction of these structures. Here's the pharyngoesophageal segment that opens and closes. Here is the esophagus. Here is the lower esophageal sphincter, and when this is opened, it allows the bolus material to enter into the stomach and eventually into the intestines. This entire esophageal phase, from the entrance of material into the esophagus until the bolus has entered into the stomach and the lower esophageal sphincter has closed, takes about 8 to 12 seconds. So it is by far the most lengthy of the the 3 phases that we have studied so far: oral, pharyngeal, and esophageal. We talked about the need for the various sphincters to open and close at the appropriate times. Difficulties at the esophageal phase we will see include difficulty opening and closing these sphincters, the lack of peristalsis so that the passage of food material becomes ineffective and essentially stagnated. And depending on other actions in the digestive tract, as we've previously mentioned, food material can travel in the wrong material, as in the case of reflux, and up into the pharynx. Certainly not something that we want to see happening when we